Very good morning, everyone. Hope all of you are having a wonderful session so far. I'm Dr. Ramakrishna, consultant from Virinchi Hospital. I'll be discussing about non-renal indications for extracorporeal therapy in critical ill patients. So what is extracorporeal therapy? In simple terms, it is nothing but a medical procedure done outside the body. It is a science that uses blood purification technologies to treat critical illnesses. Everything like extracorporeal therapies to support kidney, to support liver, cardiovascular system, and it also includes extracorporeal therapies, including the poisoning and to support sepsis. So it is not confined to a single specialty. It is interdisciplinary subject of both critical care medicine and also blood purification. So it involves the nephrology and toxicologist when we are speaking about the poisoning. It is also called as multi-organ support therapy or extracorporeal organ support. So what are all the extracorporeal therapies you can encounter in critical ill patients? There can be extracorporeal therapies which support the kidney, liver, respiratory system, cardiovascular, and so on. In all these, the most commonly encountered extracorporeal therapy as we see routinely in ICU, renal support. Examples include hemodialysis. The CRRT technique is the most commonly encountered extracorporeal therapy. Likewise, there are extracorporeal therapies which support liver, such as single-pass albumin dialysis, MARS, or extracorporeal liver assist devices. Similarly, there are extracorporeal therapies for supporting the respiratory system, such as venous ECMO, and for cardiovascular system, VA ECMO. And there are extracorporeal therapies encountered in the poisoning and also for sepsis. And since the topic is about the non-renal indication, we will not be discussing about the hemodialysis and all the techniques. And the discussion about the ECMO, that VV and VA ECMO also will not be discussed here because that is a separate topic and the extension. So in this next 30 minutes, we will be discussing about the extracorporeal therapies in the liver failure, for poisoning, and extracorporeal therapies in sepsis. But before going to that, all these therapies mainly works on this 3 or 4 mechanisms like hemodialysis or hemofiltration, nothing but convection or ultrafiltration. A third, hemoperfusion, and if I can include the fourth one, that is plasma exchange burst on centrifugation technique. So I will not be going into details of all these techniques, their working principle, but in a few summary, the hemodialysis is mainly based on simple diffusion. That is because of the concentration gradient, the molecules move from one compartment to another compartment. So the solute clearance in hemodialysis depends on the concentration gradient, molecular weight of the substance, its membrane permeability, surface area of the filter. The larger surface area, high is the clearance rate. Similarly, the blood flow rate, dialysate flow rate also determines the solute clearance. Same way, the duration of dialysis. Coming to hemofiltration technique, in this mainly the solute clearance is based on the solute drag, where the pressure in the one compartment is increased with respect to other. So this drives the water along the membrane. So along with water, the solutes are dragged into other compartment. There's nothing but called solute drag. So it is the transmembrane pressure gradient that drives which determines the solute clearance. Similarly, the ultrafiltration coefficient, there is nothing but which determines the water permeability of the membrane. The higher is the filtration coefficient, higher is the permeability. Likewise, surface area and the duration of the technique also determines the solute clearance. Coming to hemoperfusion technique, unlike the hemodialysis and hemofiltration, here we are using a separate cartridge which has got affinity for a specific substance or target molecule. So the clearance here is determined mainly by the affinity of the sorbent to the target molecule have the ability to penetrate the porous membrane, also solute size. So the first we'll deal with the extracorporeal therapies in sepsis. But before going into the technique, first we'll understand the pathogenesis of sepsis, how the inflammation sets in and how it's going to affect the organs. Whatever may be the pathogen, it is a virus, fungal, a parasite, or a bacteria, each organ expresses certain proteins on the surface, which are nothing but pathogen-associated molecular proteins. For example, in COVID-19, it is spike protein, which is a molecular protein. All these proteins are recognized by the immune cells. So this activates the immune system. First, the leukocytes gets activated. So once the leukocytes get activated, they release the interferon gamma, which activates the macrophages. The activated macrophages release various cytokines and chemokines, especially interleukin 6, interleukin 10, and tumor necrosis factor alpha. These interleukins mainly employ in contracting the infection. At the same time, they damage the surrounding cells. So the surrounding cells also express certain molecular proteins, which is called damage-associated molecular proteins. Thereby, this also activates the leukocytes. So this can lead to a vicious cycle of inflammation. Normally, mild infections, this inflammation is in a regulated fashion. But when this inflammation becomes unregulated or dysregulated in response to infection, it can lead to sepsis and the cytokine storm. So if you can see this graph, how immune response behaves to a pathogen infection over the time period. If you see, you can see the two arms here, one red color and the blue color. Red indicates inflammatory arm, the blue indicates the anti-inflammatory arm. As you can see here, once there is entry of the infection into the body, you can see as soon as the pathogen enters into the body, the inflammation sets in. The immune system is activated, thereby causing the inflammation. At the same time, there is a release of anti-inflammatory cytokines to contract the inflammation, but in the initial phase, it is the pro-inflammatory markers which are predominant compared to anti-inflammatory markers. So this A phase, also called as adaptive phase, and the B phase during the storm phase, it is mainly the pro-inflammatory markers which are in high concentration compared to anti-inflammatory cytokines. But over a period of time, the pro-inflammatory markers concentration will decrease compared to anti-inflammatory markers. So our aim of employing extracorporeal therapy is mainly during this adaptive phase of cytokine storm phase, during which the inflammatory markers are in very high concentration. So if you employ this technique during this period, you are removing the harmful effects of this inflammatory markers over the various organ systems. So this A and B phase is the phase during which the extracorporeal therapy is likely to be beneficial. Because if you employ in the late phase where the anti-inflammatory markers are in the higher concentration, the beneficial effects of anti-inflammatory markers is lost. So if you employ in the late phase, you are going to do harm than the benefit by doing this technique. So how these extracorporeal therapies are going to benefit in sepsis? Mainly, there are 4 hypotheses, but of these 2 are important. One is toxic threshold hypothesis, where by using this extracorporeal therapy, you are decreasing the cytokine concentration so that this concentration in the circulation is reduced. And the third is so that since the concentration is decreased, the effect on this damage, the deleterious effects of these cytokines on the organ systems is reduced, thereby reducing the multi-organ failure. And the second hypothesis, by restoring the concentration medium, that is, once you remove the cytokines from the circulation, the cytokines which are in the tissues will get mobilized now into the circulation, so that the leukocytes or the inflammatory cells which are present in the tissues now can effectively fight against the infection. Unlike previously, where The cytokines are in higher concentration in the tissues. So by employing this technique, you are removing the circulatory cytokines and allowing the tissue cytokines to get mobilized to the circulation so that the leukocytes and the macrophages can get concentrated in the tissues to fight against infection. The other two hypotheses, mediator hypothesis, cytokine hypothesis, has a minor role in fighting. So if you see, there are various therapies, extracorporeal therapies employed in the sepsis, which works on the following mechanism, like technique employed in the convection therapies. Example is continuous renal replacement therapy or high volume hemofiltration. The continuous renal replacement therapy, the normal renal dose is 20 to 25 ml per kg per hour. By this technique, you can remove some cytokines to some extent, but is not helpful as found in the studies. So in order to remove major cytokines or the cytokines in higher concentration, you have to do high volume hemofiltration. So what is high volume hemofiltration? Unlike the renal dose where the convection dose is 20 to 25 ml per kg per hour, in high volume hemofiltration, you have to use a larger dose, that is 30 to 35 ml per kg per hour of dose. Using that technique can remove the cytokines from the circulation. Even there are studies where they employed very high. Very high is a term used when you are using the dose of 50 to 70 ml per kg per hour for 24 hours, or 100 to 120 ml per kg per hour for a short period of 4 hours, followed by normal 20 to 25 ml kg per hour dose. So even with this technique, the cytokines can be removed effectively, but overall the studies have shown that there is not mortality benefit with this technique. Coming to second technique, which was based on the adsorption mechanism, is polymyxin B immobilized filter or the hemoadsorption technique. In case of immobilized polymyxin B, here the filter contains the polystyrene fibers on which the polymyxin B is immobilized onto it. As you all know, the polymyxin B works against the gram-negative infection. Likewise, this polymyxin B immobilized filter can be used in gram-negative infection, especially where the source is the abdomen and endotoxin, but you need to measure the endotoxin levels for this because this polymyxin B filter is found to be beneficial only when the endotoxin levels are more than 0.6 per ml. So overall, it was for a gram-negative sepsis, especially intra-abdominal sepsis with endotoxin level of more than 0.6. And most of the studies with the polymyxin, they have come from the Japan. Since 1994, this filter has been used in Japan, and the positive studies mainly are from the Japan itself. And come to another technique of hemoadsorption, where you can use a polyvinyl benzene styrene fibers to absorb cytokines. And this example is cytosorb filter. I think most of us have encountered this filter during the COVID pandemic, whereby this filter is used to remove the cytokines from the circulation. So this employed in the cytokine storm. So this as the first two techniques which are discussed so far based on either convection or hemoadsorption, where there are other techniques where the combination of these two therapies or one or more technique is employed. For example, coupled plasma filtration adsorption. Here the technique of plasma filtration along with the hemoadsorption is employed in it. First, blood from the patient is drawn. It passes through the plasma filter where the plasma is isolated from the blood. So this isolated plasma now flows through the sorbent cartridge where the cytokines or the endotoxins are get absorbed. After absorption, now the plasma combines with the blood previously separated. Now this, after combining with the blood, now this flows through the hemofiltration filter. So here the technique of plasma filtration and hemoadsorption is combined. Another technique where there's a combination of hemofiltration with hemoadsorption is using AM69 membrane. Example is the auxiliary filter. In this technique, this filter can combine both endotoxins, cytokines. At the same time, this filter is impregnated with heparin so that it can provide local anticoagulant properties also. So all in all, this has got 4 properties. It can remove cytokines, it can remove the endotoxins, it can provide renal support, it has local anticoagulant properties also. And there are other techniques employed in sepsis, include plasma exchange, electrocytopharetic devices. So this table summarizes various filters designed to remove the endotoxin cytokines in sepsis. For example, polymyxin B can bind endotoxins preventing the circulation by hemoadsorption technique. Example is the toramyxin manufactured from the Japan. And similarly, AM69 membrane, which can bind with endotoxin and cytokine using hemoadsorption and convection technique. Example is the auxiliary filter. And another one is the polystyrene divinyl benzene filter, which can bind with cytokines using hemoadsorption or conversion technique. Example is cytosol. That is all about the extracorporeal therapies, sepsis. Now we'll move on to extracorporeal therapies in the liver failure. So as we all know, liver has got tremendous capacity to regenerate. When I say regenerate, it's not about partial regeneration. It has capacity to regenerate completely. And this applies to acute liver failure and also acute and chronic liver failure. Whereas acute and chronic liver failure, it can regenerate to the baseline status. So the extracorporeal therapy can have 2 advantages in the liver failure. It can act as a bridge to recovery, buying some time to provide liver support and allowing the liver to regenerate. Or it can act as a bridge to transplant, where the spontaneous regeneration of liver is unlikely and the patient requires a transplant, but the donor is not ready and we need to buy some time, and the extracorporeal therapies can be employed in such situation to avoid other organ damages. So if you see the pathogens in the liver failure, whatever may be the insult, either it is a viral hepatitis or a toxic hepatitis or ischemic hepatitis leading to acute liver failure, what happens is the metabolism of this toxin is affected. So as we all know, the liver is the largest organ from where the toxins are metabolized in the body. As the liver is not functioning, there can be increased concentration of these toxins, which can be divided into hydrophobic and hydrophilic substances. Among the hydrophobic substances, it includes bile acids, bilirubin, prostacyclins, fatty acids, and so on. And among the hydrophilic toxins, examples ammonia, lactate, and aromatic amino acids. So in liver failure, all these hydrophobic and hydrophilic toxins gets accumulated in the body, and they can have effect on other organs leading to secondary damage. As we all know, in the liver failure, the most common organ to get insult or to get affected first is the kidneys. So all these toxins can contribute to hepatorenal syndrome. They can cause cerebral edema, hepatic encephalopathy. Similarly, they can decrease the systemic vascular resistance, decrease the mean arterial pressure, can lead to bone marrow suppression, immune paralysis, and so on. So by employing the extracorporeal therapy in liver failure, our target or aim is to remove all these toxins, hydrophilic and hydrophobic toxins from the circulation. Thereby, we can prevent the secondary organ damage. So, as I said, in liver failure, there are various toxins gets accumulated. It can be mainly albumin-bound toxins. These albumin toxins are mainly impregnated in the secondary organ damage. And other toxins include water-soluble toxins such as urea, creatinine, ammonia, and cytokines. Other form of toxins like bilirubin, bile acids, fatty acids also gets accumulated. So the extracorporeal technique aim is mainly to remove this albumin bound toxin and water-soluble toxins. So you can classify this extracorporeal liver supports into artificial and bioartificial support system. Coming to artificial liver support systems, the aim of this artificial or the technique in artificial liver support system, you are able to remove this toxin by employing this technique. So it is mainly the detoxification you can achieve using the artificial technique. Examples include albumin-based liver support systems such as MARS, which stands for molecular absorption recirculating system, or a fraction plasma separation and absorption, or a single class albumin dialysis. The second artificial liver support system is the plasma exchange. And coming to second type, that is bioartificial liver support system. Unlike artificial, here the bioartificial can provide two functions: detoxification and synthetic function, here resembling the natural liver function. Example include extracorporeal liver assist devices. So we'll discuss in brief about each of these techniques. Coming to molecular adsorbent recirculating system, as we all know, in liver failure there can be toxins which are small, hydrophobic, which mainly depend on albumin for the transport. So this mass is nothing but albumin dialysis. What is albumin dialysis? Just like a traditional dialysis, but the dialysate used here contains albumin, especially 20% albumin. So using this, we are able to extract this toxins from the body. So it not only removes albumin-bound toxins, but also the water-soluble toxins can also be removed using MARS. So if you see the circuit, this MARS contains mainly three circuits: blood circuit, albumin circuit, and dialysate circuit. You can see in this picture. So first, the blood flows from the patient through this blood circuit through the membrane. This is Mars flux membrane. This membrane is impermeable to albumin. Only the toxins get passed through this membrane into this yellow circuit. Yellow circuit is nothing but this entire is the albumin circuit. It contains 20% albumin, approximately 600 ml. So the toxins along with the albumin now passes through this dialysate circuit, passing through the diaflux membrane. Here the water-soluble toxins are removed from the circulation. Now what happens is, now this after passing through diaflux membrane, now it enters into this circuit, passes through two membranes, that is activated charcoal and the resin, thereby removing the albumin bound also hydrophobic toxins. So here it contains three circuits: blood, albumin, dialysate circuit, and in this technique you are using the extrinsic albumin. About 600 ml of 20% albumin is used to remove the toxins. So this MARS technique has been employed in both acute liver failure and acute and chronic liver failure. Among all the liver support systems, MARS is the most extensively studied and also most widely published. And using MARS in acute liver failure and acute and chronic liver failure has been shown to provide hemodynamic improvement and also improvement in hepatic encephalopathy and improvement in kidney function. Coming to second artificial liver support system, that is fraction plasma separation and absorption. The technique is similar to ours. Only difference here is it uses a large cutoff membrane. Since it is the wide pore size, it is highly permeable to albumin. So since the membrane is permeable to albumin, we are Here in this technique, the extrinsic albumin is not used. The patient's own albumin is used for removing the toxins. So the albumin is reactivated and returned to circulation using the resin and the anion exchange column. So if you can see in this picture, the fraction plasma separation and absorption contains only the two circuits, the blood circuit and the second circuit. There is no albumin circuit in this technique. First, the blood flows, the pump drives the blood from the patients to the filter, which is albu flow. It is highly permeable membrane. It is permeable to albumin. So the albumin bound toxins are removed into this circuit. So the now this plasma flows through this tube, that is the resin and also the anion exchange column, during which the toxins are removed. After that, the albumin re-enters into the circulation and return to the patient. So here we are not using any extra or extrinsic source of albumin. The patient's albumin is isolated for removing the toxins. There is a difference between the mass and the FPS. Coming to the third technique of artificial liver support is high volume plasma exchange. So when I say high volume, unlike the traditional plasma filters where 1.5 to 2 volumes of plasma is exchanged, in high volume plasma exchange, you need to exchange approximately or nearly 15% of ideal body weight of the patient with plasma. So when the patient's ideal body weight comes to 60, then you have to remove approximately 9 liters of plasma and replace with the fresh plasma. So with this technique, you are going to use a lot of manpower, lot of blood bank resources. You need to have support from the blood bank for this technique. And high volume plasma exchange has been found to provide transplant-free survival and has mortality benefit also. All in all, this technique is only recommended when the patient is not a candidate for transplant or there are any contraindications for a transplant of the liver. In that case, you can use this technique and is recommended by European guidelines. Coming to the bioartificial liver support system, which is extracorporeal liver assist device. So compared to artificial liver support system, this bioartificial systems has got two functions, detoxification and synthetic fusion, because in this technique you are using the hepatoblastoma cells, like that is HepG2C3 cells, which can carry out the functions of the hepatocytes, thereby just resembling the natural liver function. They can provide albumin synthesis and also cytochrome P450 activity. But these are new technique and there are not much studies on this, and there are currently no recommendation about this technique. Coming to the third topic, extracorporeal therapies in poison. So the poison to remove by extracorporeal technique, it has to be fulfill certain characteristics. That is the molecular weight. The lower the molecular weight, it is easy to dialyze the toxin. Example, if the molecular weight is less than 15,000, it can be easily removed by hemodialysis. Whereas if the weight is between 15,000 to 25,000, you need to employ hemofiltration or hemodiafiltration technique. If the molecular weight is more than 25,000, you need to have high cutoff membrane or a plasma exchange for removing the toxin. Similarly, volume of distribution also determines whether the toxin can be removed by extracorporeal technique or not. Because the lower the volume of distribution, easy it can be removed by extracorporeal technique. Similarly, hydrophilic or lipophilic, because the more highly the lipophilic the poison, the more it gets concentrated in the tissue, the larger the volume of distribution, difficult to remove by extracorporeal technique. The same way, protein binding and endogenous clearance will also determine whether poison can be removed by the extracorporeal technique. So the extracorporeal therapy for the poison is reserved only for a small subset of patients. And there are certain factors which determine whether this extracorporeal therapy is beneficial or not in poisoning. That is the severity of the poisoning. If it can lead to high morbidity and mortality, then extracorporeal therapy is going to help. Likewise, the availability of the antidote and its cost for the poison. Similarly, the clearance, endogenous clearance with a normal renal function and in case of renal dysfunction. And the volume of distribution also determines the success rate of the extracorporeal therapy in poisoning, and the half-life also, because we need to know the half-life of the poison, so that as we know, it takes 4 to 5 half-life for any drug or toxin to get completely eliminated, or say 95 to 99% to get eliminated from the body. So when a patient presents to you in the late phase, like after 4 to 5 half-lives of the drug removal, in that case, the toxin is already removed from eliminated from the body, so that employing any technique is not going to be beneficial in such patients. So you need to know the half-life of the toxin out. So there is a small flow chart which tells about the overall clinical approach for consideration of extracorporeal technique in poisoning. First step, you need to know whether the extracorporeal therapy will be beneficial or not. First, you should ask whether this poison is likely to cause serious morbidity and mortality. If the answer is yes, then extracorporeal therapy will be beneficial. If the poisoning is mild, not associated with any serious adverse event, then there is no benefit of using extracorporeal therapy, because in that case the risk is more than the benefit. So and then the next question we need to ask whether this toxin can be reversed by an antidote, or is there any antidote available for this poison. In that case, first role is to administer this antidote, and you need to employ extracorporeal therapy. Likewise, can the poison or the toxicity can be minimized by treatment with absorption or enhancing elimination. Say if the patient presents to you within 1 hour and the poison can be eliminated by using gastric lava activated charcoal, in that case, the role of extracorporeal therapy will be minimal. Similarly, if the endogenous clearance of the poison is more than 4 ml per minute per kg, and if the volume of distribution is more than 2 liters per kg, extracorporeal therapy is not going to be beneficial. So overall, you should consider extracorporeal therapy only when the poison is likely to cause a serious morbidity or mortality. There is no antidote available, or the cost of the antidote is very high, where the patient presents to a late phase where you cannot prevent absorption or enhance elimination. The endogenous clearance is less than 4 ml per minute per kg, or the volume of distribution is low, less than 2 liters per kg. In this case, you can employ extracorporeal therapy. So now we have decided that patients will be beneficial from extracorporeal therapy. So the next thing you need to ask is what is the protein binding of this current toxin, because it determines the technique of extracorporeal. Say if the protein binding is more than 95%, then you need to employ the therapeutic plasma exchange. If it is 80 to 95%, then you need to do hemoperfusion. If the protein binding is less than 80% for the toxin, then you can narrow down therapy based on the molecular weight. Say if it is up to 15,000, you can use hemodialysis, 15 to 25,000 hemofiltration, 25 to 50,000, you can use high cutoff membrane or hemoperfusion technique. If the molecular weight is more than 50,000, then you need to do therapeutic plasma exchange for removal of toxin. So in a brief, if the protein binding is very high, like more than 95, or if the molecular weight is more than 50,000, then only technique which is going to help is the therapeutic plasma exchange. So these are the mechanisms by which the extracorporeal therapy work in the poison, either the diffusion, convection, absorption, or centrifugation. Coming to diffusion, it is a hemodialysis technique. which removes the poisons rapidly compared to other techniques. It is not so. The benefit of this hemodialysis simultaneously corrects the urea acid base disturbance and electrolyte disturbances. Among all the techniques, it is the least expensive. And coming to hemofiltration, which works on the convection mechanism. It can remove poisons till 25,000 Daltons, unlike the diffusion, which can remove only up to 15,000. But majority of the poisons in clinical application, if you see, most of them have molecular weight less than 2,000 Daltons. So when compared to hemodialysis is not going to offer any advantage because of the clinical, because the molecular weight of most of the poisons which we see routinely as a molecular weight of less than 2,000 Daltons. So which can be, they can be removed by hemodialysis also. Coming to third technique, hemoperfusion, which was based on the hemoabsorption technique. Here you use a specialized cartridge which has got a charcoal coated on it. So the charcoal binds with the toxins which are removed from the circulation. So here the ability of the toxin or the amount of toxin which can be removed or the type of toxin which can be removed depends upon its affinity for the charcoal. So hemoperfusion or the charcoal perfusion technique is less affected by the molecular weight of protein binding. But the limiting factor here is the blood flow. The maximum blood flow which can achieve using this technique is 350 ml per minute, because increasing the blood flow, higher blood flows can cause thrombocytopenia, leukopenia, hypocalcemia. And the fourth technique, that is the plasma exchange, is based on the centrifugation technique. The disadvantage with the plasma exchange is the clearance of the toxin is very slow. It is less than 50 ml per minute. So this technique is only reserved for the poisons where protein binding is more than 95 or a molecular weight is more than 50,000 Dalton. In this case, only plasma exchange is going to be beneficial. So this technique is reserved for two indications. So the poison clearance using the extracorporeal technique can be maximized by increasing the blood flow, increasing the dialysate flow, or increasing the ultrafiltration rate, using a larger filter because it increases the surface area of the filter, which enhances the removal of solute toxins, and using the technique for longer duration. So if you see this table, the utility of extracorporeal modalities in poisoning, you can see whatever may be the technique, when the volume of distribution is less than 2 liters per kg, the extracorporeal technique is possible. If the volume of distribution is more than 2 liters per kg for the toxin, then the extracorporeal therapy is not going to benefit. If the protein binding is less than 80%, you can employ the hemodialysis high cutoff membrane CRRT technique. If protein binding is high, then either hemoperfusion, where the protein binding is between 80 to 95%, and if protein binding is more than 95%, you need to employ plasma exchange. Similarly, the molecular weight, higher molecular weight substance can be removed by plasma exchange or hemoperfusion. If you see the examples of the toxins which can be removed by hemodialysis include salicylates, toxic alcohols, or lithium. And using CRRT technique, example is lithium. Hemoperfusion technique, using the hemoperfusion, we can remove valproic acid or carbamazepine. So this removal of toxins by extracorporeal technique is reviewed by the ECCCM committee, that is extracorporeal removal in poison. They gave recommendations regarding in which poison the extracorporeal therapy is going to be beneficial. Likewise, they gave certain recommendations for extracorporeal technique and against. So they recommend extracorporeal technique for poisons like barbiturate, lithium, methanol, metformin, salicylates, thiophyllene, valproate, and so on. Similarly, the ECCCM committee doesn't recommend using this technique for removing toxins in tricyclic antidepressant or digoxin poison, because here the risk is more than the benefit. And before employing the extracorporeal technique, we need to understand the clear indication, because, for example, in methanol poisoning, you have an antidote, fomepizole. So if the antidote is not available, or when the methanol poisoning is severe, like it's leading to severe acidosis where the pH is less than 7.25, seizures causing visual disturbances, or renal failure, only in these cases you can employ this extracorporeal removal for this problem. Similarly, metformin. If you see, the metformin has got endogenous clearance of 600 ml per minute with a normal renal function. In case of renal dysfunction, the clearance is decreased. And using extracorporeal technique, the clearance what we can achieve for metformin is 240 ml per minute maximum. So if you see in a metformin poisoning or overdose, the clearance to the kidney with normal renal function is more compared to extracorporeal technique. So before employing the extracorporeal, you need to understand the clear indication. So what extra committee recommend is use extracorporeal therapy for metformin overdose only in case of renal dysfunction. I request everyone to go through this extra recommendations for to understand the clear scenario where we can use this technique for these poisons. So I conclude by saying that we need to understand clear or know the indications for each therapy, whether it is liver support systems and you're supporting the liver, or for extracorporeal therapy for poisoning or in sepsis. We need to have a clear understanding on a subset of patients, which subset of patients this technique is going to help. And not only that, you need to review these patients daily, whether this technique is going to help or not. So, for example, liver failure patient may not be candidate on the day one, but if you follow them, there might be clear indications over the days. And because only by reviewing patients daily, you can identify early which patients are going to benefit in sepsis or liver failure, because the timely intervention prevents the multi-organ failure and chances of survival is more. Thank you.